Hi, my name is Cindy Etienne, and I will be presenting the nurse assessment for the postpartum period. The postpartum period is very important on the labor and delivery unit and postpartum unit when you're assessing for your patient. Postpartum initiates from the delivery of the placenta up until weeks and possibly months after delivery. Postpartum is a critical period for a woman and her infant. This period addresses different aspects of the physical, social, and psychological changes of the mom, her baby, and her new family unit. This fourth trimester can be seen as a challenge, especially in the United States, because not every woman um, relies on someone else to help assist with the patient with having a baby and to follow up with care. You as a nurse is responsible to see to educate the patients to see what is important for them to follow up with the doctor immediately versus what is normal and what is not normal. So physical assessment, as we said, starts in the unit. This is a mom on the postpartum unit, but originally the postpartum assessment starts in the immediately after the baby is born and after the placenta is removed. Typical assessment in postpartum period is during the first hour every 15 minutes for 1 hour, in the second hour every 30 minutes, and during the first 24 hours every 4 hours. After the 24 hours, it's every 8 hours, unless there's more of an issue with the mom that deviates from the norm, then she would require more monitoring. When you're doing your assessment, you will start with the bubble acronym. When you think about bubble, the first letter for the bubble is breast. You're going to look for the size. You're going to look for the contour. Is it engorged? When you're assessing, A, B, C, D are the different aspects that you could do when you're assessing the breast. It really doesn't matter as long as you're doing the assessment, you're going to make sure that the breast is not engorged. Engorgement is important to know because there's different managements for engorgement. If the mom plans to breastfeed, you're going to encourage her to continue to breastfeed the baby or to express milk. If she does not plan to breastfeed, you want mom to put a support bra on, wear ice packs, take Tylenol as necessary, but do not, and I repeat, do not express any milk. U is the uterus. You're going to assess for height, firmness, and location of the uterus. You, as a nurse, will be responsible for palpating the appropriate way. One of your hands will be located at the mons pubis to help support the uterus so that it doesn't protrude down to the pelvic floor. As you're supporting one area, the upper hand will feel for the fundus to see if it's firm or boggy. When you're doing so, if it is boggy, you massage until firm. Also assess to see the location. Is it deviated to the side or is it midline? It's important because if it's deviated to the side, that means her bladder is full. If her bladder is full, she needs to go to the bathroom and void to make sure that this uterus stays nice and firm and midline. This picture on the side here for fundal height is an aspect to when she delivers. So when she delivers, you will see the fundus will be at the above the umbilicus. At delivery, it should be by the umbilicus or one finger breadth above. Day one, it would be below the umbilicus by 1 centimeter. By day two, it will be below the umbilicus 2 finger breadths. All the way down to day 10, you will no longer feel the uterus. B for bladder. Now, it's important for you moms to know after getting an epidural, sometimes she might not feel the urge to void or urinate. And it's important to tell her this because she might be afraid to pee and she'll be okay with not urinating. If her bladder is full, like we said before, it's going to deviate her uterus. And if it continues to deviate her uterus, she's going to start to bleed heavily. So as a nurse, you need to know when was the last time she voided. And if she voided, was it a complete bladder emptying? Did it burn? It's okay to burn the first time, but if it continues to feel Like if she continues to feel that burning, we need to assess to make sure that she doesn't have a urinary tract infection, and that's when she should notify her doctor. You, the nurse, need to notify the doctor or her patient or the patient when she's home. Bowel sounds. B for bowel sounds. Is the patient hypoactive? Is it hyperactive? Does she pass flatus? Bowel sounds is most important for the post-op patient. Bowel sounds originate, will stop moving, especially from the anesthesia and from the surgery, from all the manipulations in the intestines. As a nurse, you are responsible for doing the bowel sound assessment. And there's a systematic approach. Before you assess the fundus for a C-section patient, it's best to auscultate the bowel sounds. So you start from the right lower quadrant to the right upper quadrant, then you move over to the left upper quadrant, down to the left lower quadrant. This format helps you guide your air bubble that you're going to hear through the large intestine. Make sure that the stomach is nice and soft. And if the patient has any constipation, you could tell her she could increase her fluid intake, fiber, fruits and vegetables, and also she'll be given Colace, a stool softener. L for lochia. You're going to assess for the amount. Was there rubra, serosa, alba? What is the odor? Were there any clots? If a patient saturates her pad within 1 hour, that's a concern. So if this happens in the hospital, at least we know what's going to happen. But when she goes home, she needs to know. The reason why she needs to know is because we don't really see patients for too long after they deliver. They're usually in the hospital 2 to 3 days. We only see the rubra, but they're going to be bleeding for 6 weeks. So they need to understand the pattern with rubra, serosa, which is 4 to 10 days, and alba, which is 10 to 28 days. So it's very important when you're doing the assessment. E for episiotomy of the perineum. These are different pictures of first-degree perineal laceration, second-degree perineal laceration. It goes to the muscle, but the anal sphincter is still intact. Third degree, it goes to the anal sphincter, and fourth degree is where the whole rectum is torn. On this aspect right here, you want to make sure that if the patient has a laceration, it is well approximated. So if you look at G, well approximated means that there's no opening in the sutures. So that's why Rita is very important. The suture site, there's no redness, there's no edema, there's no ecchymosis, there's no drainage at the site, and the sutures are well approximated. E for extremities. When you look at the extremities, you want to make sure that there's no edema, there's no pain, and there's no signs of DVT. These are the things that can happen to a postpartum patient due to the fact that she's still in the hypercoagulability state, which means that she's at risk for DVTs. Her blood thickens. It's a gift and it's a curse. The reason why a patient would have blood thickening is that when she delivers, she wants to clot easily. But now that she has the baby, you don't want her to stay in bed for too long because her blood still clots easily. Just because a mom just had a baby doesn't automatically bring her back to her normal body self. It takes 6 weeks, at least 6 weeks, to get back to her normal self. Then you would assess for the emotional assessment for the mom. Is there any interaction with the family? Level of independence. How does she feel? What is her energy level? Because postpartum blues can trigger a lot of fatigue. Is there eye contact with the infant? How's her posture and comfort level with the baby? Does she sleep? Does she have any rest patterns? Be alert for mood swings, irritability, or crying episodes. So just remember, this is the acronym that we did so that we can have a loving mom and a loving unit. The breast, the uterus, the bladder, the bowel, the lochia, extremities, emotions, and episiotomy. Thank you.